Hi folks, welcome to today's Critical Care Sunday webinars. So it's not a Sunday, I know, but sometimes you have to schedule it on other days because of certain constraints. In fact, this is rescheduled. It was supposed to be held last week, but last week on Tuesday, we had some technical problems. So Dr. Riddhi Kundu, who's going to take this, he's a senior consultant in Critical Care Medicine, Ruby Hall Clinic. He's also critical care faculty for Marrow and Daily Rounds, and we are really obliged to him for sparing his time and rescheduling it. So today's topic is a very important one. Okay, it deals with sepsis, and we are going to focus on the liver, heart, and brain, and especially the heart with cardiomyopathy, which is very important since shock is an integral part of sepsis. And there we have an opportunity to intervene. In terms of brain and liver, we really can't intervene, but heart has to be understood well because we can do things with the heart. So over to you, Dr. Kundu, for the lecture.
Right, sir. Thank you for the kind introduction. So in today's lecture, this will be about 40 to 50 minutes. And in this lecture, I'm going to predominantly talk about three different systems in which are quite important from a sepsis point of view. We're going to talk about the heart. So sepsis or sepsis-related cardiomyopathy. We're also going to talk about sepsis-associated encephalopathy, and then we are going to talk a bit about the liver dysfunction that we see in sepsis, right? So we're going to kick it off by talking about sepsis-associated cardiomyopathy. So what exactly is sepsis-associated cardiomyopathy? As we know, sepsis is basically defined as a dysregulated immune response to an infection leading to a life-threatening organ dysfunction, right? So essentially, when your bacteria enters into the blood, the immune system gets activated, and this immune system, sometimes the cytokine response that we see in sepsis can secondarily lead to organ injury. So the entire concept of sepsis or septic-related cardiomyopathy was first described by a couple of gentlemen, Parker et al., who first described it in Annals of Internal Medicine way back in 1984, right? And obviously, we do not have any uniform consensus definition in terms of sepsis, but various literature, they have basically defined sepsis based on these few parameters. I'll be talking about each of these parameters in detail, but what we should understand from a gross aspect is that sepsis-related cardiomyopathy is acute and reversible. There could be either left or right heart dysfunction. Both systolic and diastolic dysfunction might coexist. There is some degrees of LV dilatation, and usually the hypotension or the hemodynamic disturbance is unresponsive to fluid resuscitation and catecholamines. But the most important part that I would want you to remember from here is that there is no coronary perfusion abnormality in these patients. So unlike ACS or unlike acute coronary syndrome, there is no acute coronary ischemia as a pathogenesis, at least in these group of patients, right? So we'll go back in history and just have a look at how septic cardiomyopathy came into being. So as I mentioned, this was Parker et al., who in 1984, so more than or almost close to 40 years now, who first described this entity in Annals of Internal Medicine. And what the authors did was that they described about a series of about 20 odd patients with sepsis-related or hemodynamic disturbances arising out of sepsis. And they found that in their cohort, the incidence of LV dysfunction was close to 65%, right? So the imaging modality or the investigation that they used to actually assess the cardiac function in these group of patients was not the transthoracic echocardiography. Rather, they used something known as a radionuclide angiography. So basically, they kind of used radionuclide studies to assess the LV function in these group of patients, right? And what the authors interestingly found out was that the patients who had a lower EF, right, the patients who had a worse cardiac function, they had a better survival, right? So this is kind of a paradox. Normally, you would expect that the patients who are having poor LV function to do worse, but at least in their cohort and maybe in a few other cohorts as well, we found similar findings. And I will talk about why this happened, but this was the first reported cohort of patients with septic cardiomyopathy. Subsequently, we had another group of patients by Jardine et al., who published their work in Critical Care Medicine in 1990, and they kind of reported similar findings of sepsis-related cardiac dysfunction. By the same time, there were a lot of animal studies as well going on, which was trying to explore the association between cardiac dysfunction and sepsis. And they found, and this was one particularly important study, which basically what the authors did or what the researchers did was that they actually inoculated animals with bacterial endotoxin. So they either used a Staph aureus or an E. coli endotoxin, both live as well as killed endotoxins. And what they found, this was the point where the endotoxins were injected, and this was the control group on the top. So the control group is there on the top. So what they found was that following injection of the endotoxin, after about 48 hours, the ejection fraction dropped. Similarly, if you look at the end-systolic volume index and as well as the end-diastolic volume indexes, they also became impaired about 48 hours following the ingestion of the endotoxins, right? But what the authors also importantly found was that after a period of around 2 to 3 days, so after about 48 to 72 hours, the ejection fraction again came back to normal in both the E. coli as well as the Staph aureus groups. So they were the ones who first did this animal experiment to find out or to actually show that this cardiovascular dysfunction that we see in sepsis, once the patient is exposed, once the animals were exposed to the serum of septic patients, this cardiovascular dysfunction is actually reversible. Though there is a drop in cardiac function, but the cardiac function can recover provided you give them enough time, right? So therein lies then comes the question is what exactly is the pathophysiology of sepsis, right? So as we know, with the basic principle of sepsis, whenever you have an infection, what you have is a dysregulated host response, right? So you have all this inflammatory mediators which are now released, and some of these inflammatory mediators, like your notably among them the TNF alpha as well as your IL beta, IL-1 beta. So these are profoundly myocardial depressant. So then they tend to depress your myocardium. They tend to actually decrease the myocardial response or the myocardial stretch response, and as a result of which the myocardial shortening is impaired, and this manifests as sepsis-related cardiac dysfunction. There is also an increase in your cyclic GMP as well as increase in your nitric oxide levels. Along with that, what happens is that the troponin I that is present in the myocardium, that also gets phosphorylated. And because of this phosphorylation, what happens is that the myocardium gets less responsive to the calcium ions. And as a result of which, the myocardial dysfunction becomes profound. Along with that, there is mitochondrial dysfunction that we know is well described in sepsis, a lot of myocardial cell apoptosis, and along with that, there might be changes in your microvasculature, endothelial dysfunction, and all of these taken together, they actually magnify or they actually propagate the LV dysfunction or the RV dysfunction or any sepsis-related cardiac dysfunction. So then we do need to know what are the main characteristics of septic cardiomyopathy or sepsis-related cardiac dysfunction. So the first one I have already told you about, it is acute and reversible, right? And this was actually demonstrated well in all subsequent cohorts. So this was done by Jardine, and subsequently there was another cohort, a big cohort of about 80 odd patients by Bohemard. And what they found was that in day 0, the EF was low, but if you gave them adequate time, there was a gradual improvement in the ejection fraction towards normal. This was another cohort by Bohemard, and as you can see over here, there are actually 3 groups. So the group which is below is the one which is highlighted in this opaque circles. These are the group of patients who had low EF. And even in this patient group who had low EF, if you give them adequate time, there was a gradual improvement in their ejection fraction towards the normal. So they actually measured the velocity time integral, and the velocity time integral, as we know, which we measure by echo, is basically kind of a proxy measure of your stroke volume. So if you give them adequate time, the cardiac function will return back to normal. So it is acute and reversible. First thing. The other important characteristic that was found in patients with septic cardiomyopathy was that this was in contrast to patients with cardiogenic shock. So what happens in cardiogenic shock is that you have low EF, right? And along with that, your filling pressures, so your CVP, your pulmonary capillary wedge pressures, and all those stuff, they will go up, right? That is what that happens because whenever you have a low EF state, the myocardial emptying is impaired, the filling is impaired, and as a result of which, the filling pressures you are expected to go up. But in septic cardiomyopathy, this was slightly different. There was a depressed EF, but this was associated with normal filling pressures, right? So this was something that was different from cardiogenic shock. So let's understand why does this happen. So if you looked at this initial cohort of patients, as you can see over here, they measured the pulmonary capillary wedge pressures using the right heart catheterization. So what they found was that the pulmonary capillary wedge pressures, these were the patients who had an EF of less than 45%, right? So in those patients, the pulmonary capillary wedge pressure was elevated, right? It was elevated to maybe 11 to 14 mmHg, but not as significantly elevated as you would expect in somebody who has a significant LV dysfunction. So why does this happen? Why are the filling pressures not elevated? So there are basically 2 mechanisms that have been described. The first mechanism that has been described is that a lot of patients with septic cardiomyopathy, they have an associated RV dysfunction, right? So whenever you have an RV dysfunction, the incidence of RV dysfunction can be as high as 30%. As you know, patients with sepsis, they have a lot of cytokines that causes pulmonary vasoconstriction. Along with that, the effect of hypoxia, hypercarbia, acidosis, and all of these can cause a form of acute pulmonary arterial hypertension, acute rise in your PA pressures. And as a result of it, this might lead to some degrees of your RV failure. Right. And this RV failure is kind of protective because of the RV failure and because of the elevated right-sided pressures. These pressures are not transmitted to the left side of your heart. And as a result of it, the left-sided pressures are not elevated as much as you would expect in somebody with a low EF. So this was the first reason. But again, RV dysfunction does not happen in all patients, right? So what was the more important cause? The more important cause that was described was a form of LV preload adaptation. So what is LV preload adaptation? So what happens in septic cardiomyopathy is that the LV chambers, they actually dilate. And because the chambers dilate, because the compliance increases, the LV filling pressures, they do not get elevated as much. So if you look at the initial study by Parker, initial study that was done in 1984, they actually reported that the LV end diastolic volume almost doubles, right, in patients with a decreased LVEF, in patients with septic cardiomyopathy. So this was the initial study, but again, the subsequent studies which were based on echocardiography and which were probably much better in assessing the actual LV dimensions, they found that the LV diastolic volume does increase, but probably not as much as was reported by the group initially by Parker et al. Right? So definitely there is some degrees of LV dilatation that actually prevents the elevation of your LV filling pressures. So these are the two main characteristics. One, acute and reversible. Second is decreased EF, but not increase in the filling pressures. So what exactly is the true incidence of septic cardiomyopathy? So this again is a controversial thing. If you look at the literature, the incidence has been reported from as low as 10% to as high as 70%, right? So why is this variable incidence, or why is this variability in terms of reporting the incidence, right? So therein comes the role of LV afterload, right? So what we know from our basic physiology is that if the LV afterload is low, the LVEF will appear better, right? And this is what exactly happens, what happens in sepsis. So if in a patient who comes in with sepsis, who is not been resuscitated yet, who is not on a norepinephrine drip, in those cases, the LV afterload will be very low, right? Because they will be vasoplegic. Their systemic vascular resistance is low. And in those cases, the stroke volume will appear better, right? On the other hand, if the same patient, if you have resuscitated the patient and if you have restored the systemic vascular resistance to normal by using a norepinephrine drip, so what has happened now is that the afterload has gone up. You have probably given him some fluid as well, and therefore the preload has also improved. So in those cases, the stroke volume might actually go down because the LV is now working against a bigger afterload. So therein lies the importance of LV afterload, and therein lies at what stage of the septic shock spectrum you are actually measuring the LV function, because based on that, the incidence of septic cardiomyopathy can vary. And this was actually beautifully illustrated by Willard Barron. Willard Barron were a group of researchers who have done a lot of work on sepsis-related cardiomyopathy, and they did a series of about 183 patients with sepsis-related hemodynamic disturbances. And these clips are actually taken from one of their studies. And if you look at this patient, this is a patient who has come in with sepsis-related hemodynamic disturbance, and they did an echo initially, and what they found was that the LV was actually hyperdynamic. It was contracting pretty well. The LV chamber size was quite small. So looking at this LV, you will not think that this patient has any degree of LV dysfunction. After a period of time, what they did was that they gave fluid resuscitated the patient, similar to a patient with septic shock. They started this patient on a norepinephrine drip, and now what happens? As you can see, the LV appears much worse. The LV dysfunction is now unmasked once you have restored the systemic vascular resistance as well as the volume status to normal, right? So now in this same patient, what they did subsequently was that now they started this patient on a Dobutamine drip. So with the Dobutamine drip, as you can see over here, the LV function now appears much better. So as you can see, even in the same patient, the spectrum of septic shock, at what stage of septic shock the patient is in, what is the loading state condition of the heart, based on that, the LV function estimation can vary. And this was actually very well demonstrated in the subsequent studies, and most notably by the same group of researchers who found that if you did a echo examination early in the course of septic shock, maybe at a time point where the systemic vascular resistance is still low, where the afterload is still low, the incidence of LV dysfunction can be less. But when you repeat the echocardiographic examination serially over a period of time, the incidence of LV dysfunction can be much higher, to the tune of about 60%, right? So what it is recommended is that, especially for actually correct estimation of septic cardiomyopathy, one needs to take into account two things. One is the loading condition of the heart. So the loading condition of the heart will vary, and also the time point at which you are doing the echocardiographic examination. So maybe you need to actually do the echocardiographic examination serially at different time points to actually have a correct assessment as to what the actual LV function is. So same group of researchers, and this was a study I was talking about previously as well. So they actually reported about a cohort of 183 patients with sepsis-related cardiac dysfunction, and they actually found that there were different groups of patients in these cohort. They found that on the y-axis, what they did was that they plotted the cardiac index. On the x-axis, they plotted the ejection fraction, right? So what they found was that there were about, if you look below cardiac index of less than 3 liters per minute, so this is zone, almost about 35% of the patients, or about 65 patients, they actually had a cardiac index of less than 3 liters per minute per meter square, right? And of them, there was this group of patients in this box who actually had an associated RV dysfunction as well. So they had a cardiac dysfunction, and about around 15 to 20% had associated RV dysfunction as well. If you look at this box, these were the group of patients who were not resuscitated. So they were having persistent vasoplegia. So because of the vasoplegia, their LV afterload was quite low. So if you looked at the ejection fraction appeared normal. So the ejection fraction was actually normal, more than 45%, right? But actually they had impaired LV intrinsic contractility, which was manifested later. On the other hand, you had another group of patients in this box in whom their LV afterload had been optimized, and these patients actually had a decreased ejection fraction once their LV afterload was normalized. So in this big cohort of patients, depending on the stage of septic shock they were in, these patients might manifest with different dysfunction, as well as depending on the loading conditions that the heart was dealing with. I hope it is clear till now. So moving forward, I also told about the initial studies by Parker et al., who showed that patients with a low EF, right? So the patients who had an EF of less than 45%, they did better, right? So their survival was actually higher, right? So normally, intuitively, what we would think is that somebody has a low EF, this patient will do worse, right? But in septic cardiomyopathy or sepsis-related dysfunction, this was not true. So there was some sort of a paradox. So what is the reason for this paradox? So this was the initial study, Parker et al. As I mentioned to you, patients with an EF of less than 0.4% or less than 40%, they had more survivors. Non-survivors were the ones who had a higher EF. See, the non-survivors were the one who had a better ejection fraction. The survivors were the one who had a low ejection fraction. So apparently what appears from this study is that if your EF is low, this appears to be protective, or this appears to give you a better chance of survival, right? From this graph. And the similar findings was reported in the subsequent cohorts as well by Jardine, by Willard-Baron, and Kumar. As you can see over here, all the non-survivor groups in the studies, they had a higher ejection fraction. So why does this happen, or why does this paradox happen in sepsis? So the reason is that there is a very important role of the afterload, right? So afterload plays a very important role whenever we are diagnosing sepsis-related cardiac dysfunction or sepsis-related cardiomyopathy. What the author suggested was that the non-survivors, though they appeared to have a better EF, so these non-survivors, they appeared to have a better EF, but that better EF was probably because the systemic vascular resistance, or SVR, was very low in this group of patients. So their afterload was very low, and therefore their LVs appeared to be better functioning. Their LVs appeared to be hypercontractile, right? But these were the group of patients who were having more profound vasoplegia. So they were actually having more profound septic shock, and therefore these were the group of patients who actually did worse. So just having a better EF does not guarantee that your patient has a better outcome. If they're having more profound vasoplegia, it might be that your LVs or LV ejection fraction is falsely appearing to be better, right? So in those cases, we need to take it with a pinch of salt. So then the next question comes is that, then what is a better marker, or what is the best marker to actually, since ejection fraction is not that good, what is a better marker to actually find out about the cardiac status of these patients, right? So what is said is that if you do a speckle tracking echocardiography, and if you do a global longitudinal strain, so GLS or global longitudinal strain, which we can find out from a speckle tracking echocardiography, that is the best marker of actual LV myocardial contractility, or the LV myocardial shortening, right? So then comes, how do we diagnose septic cardiomyopathy? Obviously, you should suspect sepsis-related cardiac dysfunction in any of your patients who presents with septic shock and is showing signs of associated organ dysfunction. So don't be hesitant to pick up the echo probe and try to actually image the patient's heart. Obviously, if the patient has a heart failure, features of fluid overload, ongoing arrhythmias, tachyarrhythmias, all those things should actually heighten your suspicion further. In the older studies, people use the pulmonary arterial catheter, but the pulmonary arterial catheter is probably not a very good modality to diagnose septic cardiomyopathy. The reason being is that the philic pressures are not elevated in this group of patients. And therefore, the echocardiography is therefore the gold standard if you're trying to diagnose sepsis-related cardiac dysfunction. So what are the echocardiographic findings? Obviously, LV dysfunction, it is manifested as a decreased cardiac output or a decreased ejection fraction. Ejection fraction per se is its own pitfalls. It is dependent on the loading conditions of the heart, the preload and the afterload. We can also measure the S wave or the velocity of the S wave, as well as the global longitudinal strain using the speckle tracking echocardiography. For the RV dysfunction, obviously, we look at the relative sizes of the RV and the LV, the TAPC, the fractional area change of the RV, something which we are usually well versed with once you are working in the ICU. And for LV dysfunction, obviously, you have to look at the septal E prime waves as well as the E prime wave ratios to find out whether the patient has an associated LV diastolic dysfunction. Is there a role for any biomarkers? So do biomarkers help in sepsis? Actually, for the diagnosis of sepsis-related cardiomyopathy, it is not that helpful because even in sepsis, even without cardiomyopathy, sometimes because of an associated renal dysfunction or CKD, these biomarkers tend to go up, right? They can be used to rule out ACS, especially if you have very high levels of biomarkers, and along with that, you do an echo, you see a regional wall motion abnormality that can help you in ruling out ACS. ECG changes, again, some of the STD changes might be non-specific and they might be found in sepsis-related cardiomyopathy as well as in ACS as well. Of the biomarkers of the troponins, troponin I and troponin T, the troponin I is actually the one which has been found to be more elevated in patients with sepsis-related cardiomyopathy. This is probably because there is a lot of myocardial apoptosis and cell leakage of troponin I that happens in patients with sepsis, right? But again, we have to remember that they may be elevated even in absence of septic cardiomyopathy, though there are a lot of studies that have actually tried to correlate the severity of rise with the overall prognosis in these group of patients. So I'll use the next 5 minutes just to talk about a bit about the management of these patients. So obviously, underlying management of sepsis is crucial. You have to treat the sepsis aggressively. And once you treat the underlying cause, you would expect the LV function to improve over a period of time. It is acute and reversible, right? But obviously, when there is a hypotension, then you have to think in terms of fluids, vasopressors, inotropes like dobutamine or levosimendan, beta blockers, as well as extracorporeal life support as well. So these are some of the aspects that I'm going to talk about. In terms of fluids, the sepsis guidelines, they recommend 30 ml per kg, right? But obviously, if your patient has developed cardiac dysfunction, you have to be more judicious. You have to be more titrated in terms of your fluid boluses, and you have to use your dynamic indices. There might be some role of fluid, especially if they're hypovolemic, if they're having central hypovolemia, but be careful not to overload them. What about vasopressors and inotropes? So the first line of vasopressor in sepsis is norepinephrine, right? And norepinephrine is even recommended if your patient shows septic cardiomyopathy because norepinephrine does also have some positive inotropic action as well. But obviously, if your patient is showing signs of persistent shock, if you're showing signs of acidosis, oliguria, signs of impaired perfusion, like a prolonged capillary refill time, even after you have optimized the fluid status and the vasopressors, in those cases, you might need to think in terms of adding a dobutamine drip, right? There was one study by Kumar, and they did about 23 patients, and they found that dobutamine responsiveness, so how your patient is responding to dobutamine, can actually predict the survival. So if the patient with septic cardiomyopathy, you start them on a dobutamine drip, maybe about 5 to 10 mics per minute. And if you see that the LV stress index is improving by a stroke work index is improving by more than 8.5, these were the group of patients, they had a chance of better survival. Right. So these are something that you can keep in your mind. Again, obviously, first you need to restore the mean arterial pressure to normal before you try any of these dobutamine trips, because dobutamine will definitely bring down your mean arterial pressure because of its beta-2 agonism, and something that we should be cognizant of. What about heart rate control in sepsis? So normally, heart rate control in somebody like a patient with a septic shock should be considered counterintuitive, right? So it is against your conventional wisdom, because what are the cons of heart rate control? You would expect the cardiac output to go down, you would expect the cardiac index to go down, and you would expect the MAP to also go down. And therefore, you would expect that all of these things they'll do is that they'll worsen your organ perfusion, right? So normally, it was believed that why give heart rate control in patients with sepsis? But then there are a few benefits of heart rate control as well. So what are the benefits? The first benefit is that it will decrease your oxygen consumption, or the myocardial oxygen consumption, right? What else? It will decrease the diastolic filling time. So it will give better perfusion. So by decreasing the filling time, it will allow better perfusion of the myocardium. It has also been found to decrease the inflammation, right? So a lot of this inflammatory response that happens in sepsis, beta blockade can actually decrease the inflammatory response. So whether beta blockade can help in patients in septic shock was actually first examined in this quite famous study that was done by Morelli et al. Way back in 2013. And they actually published this in JAMA. What they did was that they actually used a drip of esmolol. Esmolol, as we know, is a short-acting beta antagonist, right? So they have a beta blocking action. They used an infusion of esmolol and they targeted a heart rate of less than 94 for patients with septic shock. So patients who were on more than 0.1 mics per kg per minute of norepinephrine, they ran this esmolol infusion. The primary outcome was whether esmolol was able to achieve the targeted heart rate. And it was found to be significant that if you run an esmolol drip, they had a better control of their heart rate, which is kind of expected. What they also found out was that it did not affect their organ perfusion or their mean arterial pressures or their cardiac index. Mortality was again a secondary outcome. The study was actually not powered to detect mortality, but they found that there was a significant improvement in mortality with the use of esmolol. However, the study was criticized because there was a very high mortality in the control group, which was not what you expect in patients with septic shock, right? So conventionally, the mortality in patients even with fluid septic shock would expect to be around 40 to 50%. But in their patients, in their control group, the mortality was much higher. So obviously, this study was not completely a conclusive study. Recently, we had this interesting study that I was reading out. This is the stress LRCT, and this was again done in US. And what these authors did, that they used landiolol. Landiolol again is not available in India, but again it is a selective beta-1 blocker. It has more selectivity for these beta-1 receptors. In fact, 8 times more selectivity than your esmolol. They again targeted a heart rate of less than 95. There were two groups. One was the placebo. The other was the group with septic shock requiring norepinephrine. However, this study failed to show any difference in mortality. And if you look at the study was actually stopped in between because after their interim analysis of about 130 odd patients, they found that there was no mortality benefit, and they actually stopped this study because they couldn't show any outcome benefit, at least in this stress RCT, right? Obviously, people have used other agents as well. This was again a study that was actually done by my very good friend in AIMS. What they did was that they used, instead of esmolol or any of the beta blockers, they used ivabradine, right? So ivabradine is something that we often use in the ICU to control the heart rate, especially whenever we are not sure what is causing the tachycardia. Once pain and other factors have been taken care of. So ivabradine, as we know, is a funny sodium channel blocker. And what they did was they had about 30 odd patients in each group. Septic shock with tachycardia, they used enteral ivabradine for about 4 days or 96 hours. They again did not find any difference in a 30-day mortality, but the other factors like your vasopressor requirement, the stroke volume index, the cardiac index, there was not much difference between the two groups. So while it was found to be safe, it didn't reach any outcome benefit, right? This was actually unpublished data. This was something that I was working on recently, one meta-analysis that we are working on. And if we club all these studies, all these RCTs together, where does this leave us? It shows that there is some signal towards a benefit in terms of the 28-day mortality, but the benefit that was found in earlier studies, that is not replicated once you put all these studies together. So definitely, if you're using beta blockade or enteral ivabradine in your patient with sepsis, you have to be very cognizant that you are not compromising your organ perfusion, and therefore you should try to monitor your cardiac index or cardiac output, right? Otherwise, you might end up causing more harm, and definitely we should not use it as a routine in our group of patients. So finally comes the role of VECMO. Is there a role of VECMO or extracorporeal life support? So what ECMO does is that normally it will decrease your preload, right? VECMO, because it is taking blood from the venous side of the circulation and it is pushing that blood into the arterial side, right? So it will decrease your preload. It will increase your afterload, right? And by increasing your afterload, it actually worsens your native cardiac output. So the native cardiac output actually drops with VECMO, right? So is there a role of VECMO in patients with septic shock? So this question was actually assessed in two important studies. This was a retrospective study. This was done by the ELSO register, and what they did was that they studied about 80 odd patients who had severe cardiac dysfunction in patients with septic shock, so cardiac index of less than 3 liters, and they compared it with a propensity score matching to another group of patients who did not have sepsis-related cardiac dysfunction. And they found that the ECMO use was associated with improved survival in this group of patients who had a cardiac index of less than 3, right? So if your patient is having a very poor cardiac output, in those cases, ECMO might help. This was again a meta-regression analysis that was published in 2021. They took about 14 studies, 468 patients, The median time to ECMO support was about 23 hours. And they found that while the overall survival in these patients was 36%, in patients who had a poor EF, the survival was much better. So what both these studies tell us that if your EF is low, in those cases, or very low, in those cases, ECMO will help, right? But if your EF is normal, so they are predominantly having a vasoplegic shock, right? So they are predominantly having a vasoplegic shock. In those cases, ECMO will actually worsen your vasoplegia, will worsen your MAP, and in those cases, the ECMO will not help, right? So use ECMO judiciously only in those patients who are having very severe LV dysfunction, at least based on the literature that we have till now. So moving forward, I'll talk a bit about sepsis-associated encephalopathy as well as liver dysfunctions. Sepsis-associated encephalopathy is basically a form of diffuse brain dysfunction that happens in patients with sepsis or septic shock. It is usually acute in onset. The encephalopathy can manifest itself variably from mild disturbances in cognition or concentration to a more profound coma. The incidence of sepsis-associated encephalopathy is quite variable. The reason is that there is no uniform definition for how to assess sepsis-associated encephalopathy. So the incidence has been from as low as 10 to 15% to, if you look at the recent MIMIC-4 database, which is basically a US-based database, they have reported the incidence can be as high as 70%, right? And obviously, it is the most common cause for encephalopathy in the ICU. So again, pathophysiology, why does it happen? So it is kind of similar to that sepsis and cytokine storm that we already talked about. So you have sepsis and you have this inflammatory mediators. So what these inflammatory mediators will do is that they will cause the dysfunction of the blood-brain barrier. As a result of which, what happens that all your inflammatory mediators, they will now gain entry into the brain. So once your blood-brain barrier is disrupted, the inflammatory mediators now gain entry into the brain and they cause activation of the astroglia. So the astroglia are one of the main immune cells of the brain. They are basically found around your neurons. And they, once this microglia and the astroglia are activated, what they cause is they cause a propagation of the inflammatory response. So they lead to secondary immune responses in the brain. They lead to microcellular brain injury. They propagate and amplify the neuroinflammatory processes. If the patient has an associated metabolic dysfunction, like your hypoxia, hypercarbia, blood sugar disturbances, fluctuation in blood sugars, altered cerebral metabolism, as well as micro and macrocirculatory dysfunction, maybe because of a decrease in your mean arterial pressure, or if the patient is having associated endothelial dysfunction, this all can actually amplify again your encephalopathy. And the encephalopathy can actually lead to increased neuronal excitability, that can lead to seizures, it can lead to microhemorrhages, it can even lead to local areas of infarcts, as well as it can lead to all sorts of microhemorrhages as well as lacunar infarcts as well, and white matter ischemic changes. So this is in a nutshell how sepsis-associated encephalopathy takes place. Obviously, if you look at the risk factors, there are non-modifiable risk factors. For example, older age, patients with pre-existing kidney diseases, liver diseases, patients on antipsychotic medications, on psychotropic drugs, or patients with pre-existing psychiatric histories. Right? These are the patients who are more liable to develop encephalopathy in the ICU. There are certain modifiable risk factors, the ones we should be more cognizant of, because these are something that we can avoid, right? So you should avoid all sorts of metabolic disturbances in your patients, especially hypo and hyperglycemias, hyper and hyponatremias, as well as hypercarbias. Of the modifiable drugs, or the drugs which are known to be associated with sepsis-associated encephalopathy, one is midazolam. Midazolam, obviously, we know benzos are associated with a lot of delirium as well, so something that we have been trying to actively reduce in the ICU. The other antibiotic which is quite significant in causing sepsis-associated encephalopathy is cefepime. I'll be talking about a bit later. But again, mechanical ventilation, renal dysfunction, septic shock, all of these factors can actually be important risk factors for sepsis-associated encephalopathy. So how to diagnose it? Obviously, clinically, you will look for any disturbances in alterations in consciousness, cognitive disturbances. The patient might clinically be showing a seizure. Your comatose patient might be showing non-convulsive seizures. And in those cases, the importance of investigation takes place. CT is non-contributory. CT is not able to detect abnormalities in most cases. Less than 10% of cases, it can be diagnostic. So what is recommended is you do an MRI. And in MRI, you always look for a diffusion weighted sequence, because what you are essentially trying to look at is micro ischemic changes or lacunar infarcts or white matter changes, right? And these would be much better picked up with a diffusion weighted sequence of your MRI. Obviously, if your patient is showing focal signs, showing a seizure, showing persistent encephalopathy or brainstem symptoms, in those cases, you will need to do an MRI. Obviously, the problem with MRI is that your patient might be in septic shock and therefore might not be stable enough to be shifted to the MRI room or the MRI suit, right? But if you're able to have an MRI, then you might be able to see some of the characteristic changes that are seen in sepsis-associated encephalopathy. As I mentioned to you, white matter changes are quite common, right? The patient might show changes of posterior reversible encephalopathy, and finally, the patient might also show changes of ischemia. So ischemia can be seen in about 20% cases. White matter changes can be seen in about 20 to 30% of cases, and you might even see changes of posterior reversible encephalopathy. So this is again a patient with urosepsis and bacteremia who came in with sepsis, and as you can see over here, the flare images, they show some of these high signals in the flare images, and these are actually septic emboli, right? And there is another patient who had come in with community-acquired pneumonia. You would be able to appreciate this old MC infarct in this patient, but along with that, you can see all these high signals in the flare images with restricted diffusion, which indicate there is some amount of ischemic changes that are happening because as a consequence of the sepsis-associated encephalopathy. What about other investigations? Will an EEG help? Well, EEG is useful to rule out something like a non-convulsive status, especially if you are thinking in those terms in your patient. It can also be used for neuroprognostication. The problem with EEG is that while it is very sensitive for picking up sepsis-associated encephalopathy, but it is not specific enough. Other encephalopathies might also show similar EEG abnormalities. And the biggest con is that in ICU, a lot of times these patients are put on some sort of sedation like a benzos or propofol, and some of these sedations or sedative drugs might even cause some degrees of EEG abnormalities. For example, your propofol is known to cause slowing of the EEG waves, and in those cases, your EEG might not be conclusive. But what has been described in the literature is that if your EEG is showing characteristic patterns like your burst suppression pattern, absence of reactivity, or periodic discharges, these are the ones which are associated with a high risk of mortality, right? And again, if your patient is showing electrocardiographic seizures, so non-convulsive seizures, these patients are at a very high risk for developing long-term epilepsy. And this can be found in about 30% of your patients with sepsis-associated encephalopathy. So if you have the facility, you can think of doing an EEG. What about adjunct investigations like your biomarkers, evoked potentials? So biomarkers, all of these have been studied, like your neuron-specific enolase, neurofibrillary filaments, as well as your glial fibrillary acid protein. But these are mainly for research. They are not routinely used for diagnosis. Among them, I would just like to mention about this fibrillary acid protein. This is actually produced by the astroglia. So astroglia are one of the central cells that are important in the pathogenesis of sepsis-associated encephalopathy. So if you have an increased GFAP, definitely this is something which is quite important. In terms of evoked potentials, they're different from EEG in the sense that they are stimulus induced. So they actually are, you give the neurons a stimulus and then the neurons discharge, and you kind of take a summation of those neuronal responses to find out your somatosensory or your brainstem auditory evoked potentials. And they are actually impaired in patients with sepsis, especially if you know the N20 potentials, they are found to be impaired in patients with hypoxic brain injury. Similar, your cortical somatosensory evoked potentials can be impaired in patients with your sepsis-associated encephalopathy. But again, because this is not available routinely, this is usually routinely not done, right? What about how do we diagnose it then? So obviously, if your patient comes in with sepsis and is showing signs of encephalopathy, you have to rule out confounding factors like all your metabolic disturbances. If your patient is alcoholic, you have to think in terms of thiamine deficiencies, also blood sugar fluctuations, hypoglycemias, all those things you have to rule out, even electrolyte disturbances. Obviously, along with that, you have to search for the underlying sepsis, right? So you have to look for focal signs, abnormal fever, meningismal signs of bacteremia. Along with that, if the patient is showing signs of focal signs like abnormal brainstem responses, you have to think in terms of neuroimaging, either a CT or MRI. And finally, if you are thinking in terms of meningitis, you might need to do a CSF analysis as well. If your patient is actively throwing a seizure, in those cases, neuroimaging, and along with that, you might need to redo EEG. You might need to, if the patient is already on antiepileptics, you might need to do a therapeutic drug monitoring for the antiepileptics. And if your patient is having a chronic liver disease, then you have to also think in terms of hyperammonemia as a cause for your sepsis-associated encephalopathy. And finally, if the patient is showing persistent encephalopathy, then you have to think in terms of ruling out endocrinopathies. So obviously, this is in a nutshell how you go about it. Obviously, there could be causes other than these as well, but definitely imaging, working out for the sepsis, ruling out endocrine disturbances, as well as therapeutic drug monitoring are probably some of the, along with confounding factors, are some of the broad headings that we should think of. So how do we manage sepsis-associated encephalopathy? Is there any particular drug that can make it better? Unfortunately not. So you treat the sepsis, right? And you try to minimize, maintain your airway breathing circulation, treat the sepsis, good housekeeping like delirium prevention, following your ABCDF bundle, all those things will help, right? Avoid benzodiazepines as much as possible, correct your metabolic disturbances, and minimize your secondary brain injury. So metabolic disturbances like sodium disturbances, glycemia, hypercapnia should be avoided. Management of renal failure is important, and obviously you have to limit the use of benzos as well as neurotoxic antibiotics like your cefepime, right? But again, along with that, you have to think in terms of minimizing your secondary brain injury. So of the secondary brain injury factors which are known to minimize, like you maintaining your normal MAP, hypoxia, avoiding hypercarbia, maintaining normal temperature. Fever can again worsen your encephalopathy. Hypernatremia can worsen your encephalopathy, both hyponatremia as well. Maintaining normal blood sugar levels, as well as maintaining a hemoglobin more than 7 grams per day to maintain adequate oxygen levels in your brain. All of these things can actually help in minimizing your secondary brain injury, right? I'll also mention briefly about the antibiotic-associated encephalopathy. So this is something that is seen with antibiotics and something that has been described recently. So it can be acute onset or it can be subacute onset. The acute onset encephalopathy can again present with clinical seizures or myoclonus, which is usually seen with your cephalosporins or penicillin. It can also present only with psychosis, which is more commonly described with your quinolones or macrolides. Or it can be a subacute onset with cerebellar signs, which is typically seen with metronidazole. If you do an EEG, you might see some sort of a diffuse slowing or even periodic discharges in your patient, right? And of the antibiotics, the one which is most notorious in causing sepsis-associated encephalopathy is definitely your cefepime. In fact, there are a few retrospective reviews which have mentioned that the incidence can be as high as 20%. Usually it develops about 4 days following introduction of therapy, and clinically it may manifest as seizures, it may manifest as myoclonus, or it can even manifest as a non-convulsive status, right? And the treatment is usually stopping the drug, and after you stop the drug by 3 days, usually this will revert back, right? So this is something that you should think of, especially if you are using cefepime. And a trough level of more than 20 micrograms per ml is associated with the development of sepsis-associated encephalopathy, or rather antibiotic-associated encephalopathy. So this is something that is a newer entity, that is something that we should be also aware of, especially if you're using this 4th generation cephalosporin. So what are the long-term outcomes? So we came to know that sepsis-related cardiac dysfunction is reversible. But unfortunately, encephalopathy is not reversible, or not always reversible. Some of these patients, they can have long-term cognitive, physical, psychiatric, as well as social disabilities. They can have cognitive impairment in the long term. They can have neuropsychological sequelae. They can have post-traumatic stress disorders. They can have epilepsy, especially your patients with non-convulsive status, and this can actually increase their long-term mortality. And even in the short term, these are, if patient has sepsis-associated encephalopathy, they are likely to be longer on the ventilator. They are likely to have a worse outcome in terms of their ICU stay. So that is all about sepsis-associated encephalopathy. So the final part, I'll just be talking a bit about the sepsis-associated liver injury. So liver injury in sepsis, the incidence is much lower compared to other organ failures. However, the mortality can be quite high. The incidence is lower simply because the liver is very tolerant of hypoxic and ischemic insults compared to the other organs. But once the liver develops a dysfunction, the mortality can actually be quite high. The spectrum can be in the form of either hypoxic hepatitis, sepsis-induced cholestasis, or secondary sclerosing cholangitis, right? So secondary sclerosing cholangitis, it is much more rare. It happens when there is an inflammatory destruction of the bile ducts, and usually happens as a consequence of hypotension, hypoxia, as well as hepatocellular dysfunction and bile endothelial dysfunction that can happen in patients with severe septic shock. This will usually require a liver transplantation, and the prognosis is very poor. So while its incidence is low, the prognosis of secondary sclerosing cholangitis is much worse. So when we try to understand the pathophysiology of liver dysfunction that happens in sepsis or hepatitis, we have to think about the gut-liver axis. So as we know, the gut is a very important site for our protective immune defenses, right? That is the reason there is a lot of natural protective bacteria in the gut. They actually prevent the pathogenic bacteria from growing. Along with that, the gut barrier mucosal function prevents all these toxicogenic bacteria as well as the endotoxins from gaining entry into the circulation. However, because of an altered microbiota that can happen in patients with sepsis because of the effect of drugs, because of parenteral nutrition, or because of the systemic inflammatory response per se, the gut barrier mucosal function can get destroyed. And once it gets destroyed, all these endotoxins now gain entry into the liver via the portal vein and the hepatic artery. And then the liver gets exposed to all those endotoxins and all those bacterial products, right? So this is your gut barrier function. These are your intracellular junctions. These are tight junctions. But when you have a sepsis, you have all these inflammatory mediators like your TNF and IL. They can actually destroy your gut barrier function. They can lead to the migration of this bacteria through the paracellular pathways, and they directly reach the systemic circulation, the portal vein and the hepatic artery, and finally they'll reach the liver. So once the bacterial endotoxins they reach the liver, there they reach the hepatic sinusoids. And in the hepatic sinusoid, they basically encounter two cells. One is your Kupffer cells, the other one is your stellate cells. So these Kupffer cells and the stellate cells, they are useful for clearing all these bacterial endotoxins from the circulation. So they actually recognize your pathogen-associated molecular patterns, and they trigger an inflammatory response, and they try to clear the bacterial endotoxins from the circulation. But in florid sepsis, when there's a large amount of endotoxin, when the bacterial load is too high, what happens is that the Kupffer cells and the stellate cells, they now get activated, and they release large amounts of chemokines as well as cytokines. So all your cytokines like your TNF and IL-6 are released, chemokines like CCL2 is released, and that leads to secondary recruitment of the neutrophil extracellular traps, as well as acute phase proteins, and that leads to amplification of the immune response. And that can secondarily lead to injury of the hepatocytes. And this is what exactly happens in patients with septic shock. Florid sepsis, activation of the immune responses, alteration in the normal immune defense mechanism or the normal immune defense milieu, which is existence within the liver, present within the liver, and as a result of which there gets what we see is a very pro-inflammatory environment that is now developing within the hepatocyte, and that secondarily leads to organ injury. So gut barrier disruption is the first step. Bacteria gets entered into the liver now tries to clear the bacteria, but there is a lot of cytokine response, and the cytokine response can actually worsen your liver dysfunction as well, liver function, and it can also secondarily lead to gut barrier disruption as well. And along with that, there is an important role of bile acids as well. So as we know, the liver is a site of synthesis of the bile acids, which get synthesized from the cholesterol, right? So in cases of sepsis, the bile acid metabolism, normally what happens is the bile acid goes from the liver, it reaches the intestine, there it is deconjugated by the bacteria, and then it undergoes enterohepatic circulation. But this normal transport of bile or the enterohepatic cycle is now impaired in patients with sepsis. As a result of which, some of this bile deconjugation also doesn't take place. The protective effect of bile on the gastrointestinal mucosa is lost, and that kind of leads to a worsening of your gut barrier function. So all of these things can add to the problems in patients with sepsis. So what is the spectrum of liver injury? The spectrum of liver injury can take in the form of hypoxic hepatitis, which basically, as we can see from the name itself, there is an impaired oxygen delivery. So this will primarily affect your hepatocytes and usually manifest with a rise in your liver enzymes or transaminitis. Sepsis, it can lead to both hepatocellular dysfunction. It can also lead to cholestasis as well because of impaired bile acid transport and impaired bile acid metabolism. And then you have the effect of parenteral nutrition and drugs. So if your patient is having hypoxic injury, which can be seen in patients with sepsis because of a septic shock and low mean arterial pressure, low perfusion, so your shock states and global hypoxia, it can also be seen in patients with congestive hepatopathy, like your patients with cardiac failure. So what will happen? Your aminotransferases will go up. They'll shoot through the roof. They'll be more than 10 times, can be even more than 20 times. The incidence of hypoxic liver injury is about 10%, but once that develops, the mortality can be more than 50% and can be as high as 80%. They will have deranged INRs. They might even affect the liver secondarily. So renal functions might even also get worsened. Cholestatic liver injury, slightly better prognosis, happens because of an impaired biliary acid metabolism, but there can be associated hepatocellular dysfunction in these patients. We usually will do a USG to rule out biliary obstruction. So usually the sepsis-related cholestasis, they will not have any physical obstruction to the biliary flow, right? But rather they will have impairment of the transporters. They'll clinically manifest with a increase in their alkaline phosphatase as well as your gamma GGT. Obviously, you have to rule out hemolysis, drugs, and transfusion reactions. Finally, your drugs and TPN. So with drugs, the liver injury can be either be dose-related or it can be idiosyncratic. Idiosyncratic is kind of a hypersensitive response. It can present with a hepatocellular picture or a cholestatic or even a mixed kind of a picture. Parenteral nutrition has also been known to worsen sepsis-related cholestasis, and it usually presents with a mixed pattern of LFT derangement, right? The parenteral nutrition, again, it is believed to because of a impaired bile acid transport. Obviously, just for the sake of completion, I've kept this slide. There are a lot of drugs that are implicated in drug-induced liver injury. Some of these drugs are also, we are giving them in the ICU, like your ATTs are very important, at least in the Indian context. Amiodarone, your antiepileptics, they can also actually worsen your drug-induced liver injury. But obviously, in the Indian context, there are certain tropical infections as well that we need to think of that can actually present with liver dysfunction. Not just your hepatotrophic viruses like your hepatitis A and hepatitis C, but tropical infections like your malaria, they can present with conjugated hyperbilirubinemia. Dengue can present with transaminitis along with your thrombocytopenia. Leptospirosis usually presents with a raised bilirubin with relatively normal transaminase levels. And then obviously you have scrub typhus and amoebiasis that can present with conjugated hyperbilirubinemia. So whenever you, in the Indian context, you are dealing with somebody with sepsis and liver dysfunction, you also have to think in terms of tropical infections, because some of these things can be easily treated and some of these things can be easily managed, right? So how do you diagnose liver injury? Obviously, it is kind of investigation based. You do your LFTs. AST and ALT elevation would be more common in patients with hypoxic hepatitis, but can also be seen in patients with drug-induced liver injury as well as in your congestive hepatopathy. The liver enzyme levels can go to more than 10 or 20 times. ALP would be elevated in your cholestasis, which can be seen in patients with biliary obstruction as well as in sepsis-related stasis. Bilirubin elevation, you have to see whether it is a direct fraction or an indirect fraction. If it is your indirect fraction, it is probably because of excessive hemolysis. On the other hand, if it is your direct fraction, that can be because of your sepsis-related cholestasis. It can also happen because of ischemic damage to the biliary cholangiocytes. Albumin, negative phase reactant, so it might go down even in patients with sepsis. But again, low albumin levels can be found in patients with liver failure. And INR, again, it is usually a marker of hepatic synthetic function and can be impaired or deranged with liver injury or failure, but also because of the effect of certain drugs like your warfarin. So what are the general principles of management? Obviously, you have to identify early, have a high clinical suspicion, do your LFTs, search for etiology, looking at what kind of picture the patient is presenting with, whether it is a hepatocellular picture, a cholestatic picture, or whether it's a mixed picture that might give you some clue. You have to do a USG and even an MRCP when appropriate. USG might help you to rule out a physical cause for biliary obstruction. It is also important to rule out non-liver causes like your hemolysis that might be seen in patients with certain drugs, or even in patients with TTP that might cause some amount of microangiopathic hemolysis. At all times, it is important that we try to avoid and minimize the hepatotoxic medications. This might not always be possible in the ICU because we are kind of dealing with a plethora of drugs. N-acetylcysteine obviously is useful not just for acetaminophen-induced drug-induced liver injury, but also in non-acetaminophen-related liver injuries as well. Obviously, you have to treat the give antibiotics, treat the sepsis. You have to consider doxycycline, especially if your patient is presenting with leptospirosis or scrub typhus. And along with that, all supportive therapy like maintaining your MAP, fluid, and electrolyte balance. Right. So this is in a nutshell how you manage sepsis-related liver dysfunction. There is no magic bullet. There is no specific antidote, but you have to take care of the basic causes and treat them appropriately. So that is all about the sepsis-related organ dysfunction. I'll end here. Do let me know if you have any questions, or sir, if you have any questions from your side.
Thanks, Dr. Kundu. Very nice lecture, especially cardiomyopathy in details, and of course, hepatitis and septic encephalopathy. There is not, just close the presentation, your share screen.
Just 1 minute, sir. Right, sir. Yes.
So there is not much we can do in terms of intervention except in septic cardiomyopathy. And for septic cardiomyopathy, once you realize it's septic cardiomyopathy, the hallmark, like he said, is the EF will be low, but the EF is dependent on the SVR also. That is one very important thing to realize. Nonetheless, if EF is less than 40%, it qualifies as septic cardiomyopathy. And then if the patient cardiac output is low, if you can measure the cardiac output, or if the map is not coming up, then you add dobutamine to norepinephrine. And you can also, just give epinephrine instead of norepinephrine plus dobutamine in this setting. So if the patient is on norepinephrine and you want to add dobutamine, you can add dobutamine, or you can taper it off and just give norepinephrine, because epinephrine has a beta-win stimulant action also, and on higher doses, it also causes vasoconstriction. So that is the one thing. And septic cardiomyopathy, it has to be realized, causes low cardiac output. So it is a cause of a low cardiac output situation in septic shock. Septic shock, we all know, is high cardiac output. But sometimes patients can present even with low cardiac output, and these patients are the ones who are having already a low EF because of septic cardiomyopathy. Or sometimes, they may be having a normal EF, but have lost a lot of fluids, not got replacement, and are coming late. So low cardiac output, one of the causes is a low EF for a septic cardiomyopathy. And of course, troponins will not be so high in these patients. Wall motion abnormality may or may not be there. It can be global, or wall motion may be there, regional wall motion. You should not confuse it with acute coronary syndrome. That's the biggest thing, because patients may present with cardiomyopathy at the outset itself. You do a echo, you get wall motion abnormalities, patient is cold, you might think he has a MI. Troponin is also high. So please, you have to distinguish this from myocardial infarction or acute coronary syndrome. And the other thing is about encephalopathy. So in encephalopathy, when the patient comes to you, he has a high respiratory rate, often and is in respiratory alkalosis. So the cause for this is septic encephalopathy. One of the causes, of course, the RR can be high because of lung injury also, but if the lungs are normal and there is no ongoing, the patient is primarily in respiratory alkalosis, then the cause is septic encephalopathy. And also it has to be realized that septic encephalopathy, though normally non-focal, normally it is non-focal, just causes drowsiness, which is present generally at the outset itself when the patient comes to you. And it is more common in elderly because cerebral symptoms are often more common in the elderly because the brain becomes dysfunctional as you grow older and older. It becomes slower. And they can, like Dr. Kundu showed you, I think he told you, did not show you, he showed you some focal signs also, white matter densities. They can be focal abscesses because of bacteremia. It has been reported, and you can get focal signs. And if the patient is not, recovering from septic encephalopathy or drowsiness of unclear cause, then one should do a EEG to rule out non-convulsive status. That can be there. And there is no specific treatment. You have to do the ABCD if care bundles like for delirium. And finally, hepatitis. So hepatitis, two primary causes. One is your cholestasis, like I told you, and the other is sometimes you get ischemic injury because of dramatic drop in your blood pressure. There is hypoxic or ischemic hepatitis. And what kind of LFTs do you get? Classically, bilirubin and serum alkaline phosphatase is high because there is a cholestasis, it's an obstructive kind of a picture. But sometimes, the cytokines go and directly damage the hepatocytes. So you can also get elevation in OTPT also, or bilirubin. So it's a mixed picture, but the commonest picture is bilirubin and serum alkaline phosphatase high, or just isolated serum alkaline phosphatase high. And, bilirubin levels can go very high. They can go 20, 25 also at times I've seen, but the septic hepatitis does not cause acute liver failure. That is very important. It does not cause acute liver failure. So those are just a few points I wanted to make. And I think there are no questions from the audience. Dr. Kundu, you want to add anything finally?
So only other thing I wanted to add, as you told, like dobutamine and epinephrine, the other inotrop that has been used is levosimendan in this group of patients, which is a calcium sensitizer. The biggest trial that was done in levosimendan in patients with septic cardiomyopathy, but they not specifically in septic cardiomyopathy, but the Leopards trial, they didn't find any benefit. But other than that, there are kind of mixed results. So people have also used levosimendan as a positive inotropic agent in these group of patients. But again, the outcome benefits are not conclusive.
Yeah, levosimendan continues to be a controversial drug. The trials have not shown its benefit, but people are using it, and I think as time goes by, one might find some positive trials. Well, the problem is evidence, but people are finding it useful. People are using it. Someone has to draw one's own experience, and So I think with that we'll end, Dr. Kundu.
Yes, sir. Thank you.
Okay, thank you so much, and I thank the audience for their patience and for the hearing. Thank you so much. Till the next webinar. So on Sunday we'll be doing a case this time. It's been a long time since we did a case discussion. This will be from All India Institute of Medical Sciences, and it'll be on acute hypoxemic respiratory failure, 4 p.m. Thank you so much, Indian Standard Time.